Today, we'll discuss about Eastern Equine Encephalitis, which is caused by a virus spread to people through the bite of an infected mosquito. It's a rare but serious disease. And the case fatality rate is up to 41%, and the neurological sequelae can occur in 50% of the survivors. So, Eastern Equine Encephalitis is caused by Eastern Equine Encephalitis virus, which is an arbovirus in the Tocaviridae family and the alphavirus genus. This virus is maintained by a cycle between birds and predominantly Culiceta melanura mosquitoes. However, other mosquitoes are also involved in the transmission of this disease, including the Aedes mosquitoes. So mosquitoes get infected and they transmit this virus during the blood feeding to the birds and other opportunistic mammals and reptiles and amphibians. Virus can sometimes escape the usual reservoir to infect dead-end hosts like humans, swine. Humans are basically described as the dead-end host because the viremia levels are not usually reached to a level to allow the transmission to the feeding mosquitoes. Now let's talk about the pathogenesis of this disease. So when a mosquito bites a person, this virus is inoculated into the dermal tissue, and in the dermal tissue it starts to affect the dendritic cells and the Langerhans cells, and slowly this virus migrates to the lymphoid tissues where the virus replication occurs, and ultimately there is viremia and the systemic virus shedding. This virus was first identified in humans in 1938 during an important outbreak affecting Massachusetts, US. From 2003 till now, there has been multiple cases reported, and there was a multi-state outbreak in the United States in 2019 involving 38 cases. And recently, in 2024, there is increased number of cases reported in the US. So the peak incidence usually occurs in the August and the September. The incubation period for this Eastern Equine Encephalitis is around 3 to 10 days. And patients most of the time are asymptomatic. 96% of the patients are asymptomatic. However, patient can present with fever, headache, malaise, chills, arthralgia, nausea, vomiting, and less than 5% of the patient develop meningitis or encephalitis. So the neurological symptoms, they usually appear in the first 5 days, and patient can present with altered mental status, seizure, paresthesia, or focal weakness. The symptoms of this disease are almost similar to the other encephalitis, and it's very difficult to differentiate among them. So the thorough history to assess the possible Eastern Equine virus exposure and the epidemiological risk factor is important. Similarly, the detailed travel history and the complete physical examination, basically the neurological examination, is also important. So the major differential diagnosis include measles, mumps, ecovirus, which can cause encephalitis, as well as sometimes we have to consider the prion disease like Creutzfeldt-Jakob disease as well. So for the evaluation and the diagnosis, we can do the complete blood count, which can show the peripheral leukocytosis. Similarly, hyponatremia is associated with this Eastern Equine Encephalitis and is an important lab finding. In the CSF, there can be neutrophilic pleocytosis with elevated protein concentration and the increase in the IgM antibody. Moreover, we can go for the specific diagnostic tests like PCR from the blood, CSF, or tissues. And sometimes serology can also help in the diagnosis. In some cases, histopathology can help in the diagnosis. However, the brain histopathology is unspecific, but there can be findings like perivascular lymphohistiocytic coughing, leptomeningeal vascular congestion, hemorrhage, encephalomalacia, and rarely pyogenic meningeal exudates. Similarly, there can be the features of focal infiltration of the neutrophils and macrophages in the brain parenchyma, causing neuronal destruction, focal necrosis, and local demyelination resulting in the glial nodules. Imaging modality like MRI and CT scan can be useful for the diagnosis. MRI is more sensitive than the CT scan. This infection usually infects basal ganglia, thalamus, brainstem, and the cerebral cortex. MRI can report a pattern of focal lesions without significant edema. There can be a symmetric pattern of T2 hyperintensity in the lentiform nuclei. Similarly, there can be the marked hyperintensities in the internal capsules, which are known as the parenthesis sign. And this parenthesis sign may help to differentiate between the Eastern Equine Encephalitis and other forms of the encephalitis. So this is a MRI of a patient with Eastern Equine Encephalitis. In this MRI, you can see marked linear hyperintensities in the external capsule as well as in the areas of the internal capsule. So this finding is known as parenthesis sign, and it helps to differentiate between the Eastern Equine Encephalitis and other forms of the encephalitis. Basically, it helps to differentiate the Eastern Equine Encephalitis with the herpes encephalitis. Similarly, we can perform the EEG for the diagnosis. However, it is not specific, and it will just show the generalized flowing and disorganization of the background and some epileptiform discharges. Treatment of the Eastern Equine Encephalitis is basically supportive, like ICU care, ventilator support, and the management of the other symptoms. There is no antiviral drug proven to be beneficial for this infection, and it is not necessary to isolate the patients. And if the encephalitis worsens, routine intracranial pressure monitoring should be done, and the cerebral pressure directed therapies can be started. Sometimes the patient might require decompressive craniotomy, and there has been some evidence of benefit with immunoglobulin therapy. However, the use of corticosteroid has been associated with the worse outcomes. So most of the complications include the neurological complications like cognitive, motor, sensory deficit, seizures, paralysis, intellectual disability, and sometimes even the behavioral changes like psychosis. Sometimes this infection can cause multi-organ failure, autonomic dysfunction, and even death. And there has been few case reports of hemophagocytic lymphohistiocytosis after Eastern Equine Encephalitis virus infection. This is the most severe form of the arboviral encephalitis, and the case fatality rate is around 41%, and death can occur within 3 to 5 days of the infection. And in around 50% of the patients affected by this disease, there can be neurological disability. Similarly, the severe hyponatremia, presence of EEG abnormalities, presence of high CS of pleocytosis, and the treatment with the corticosteroids are associated with the poor outcomes. Vaccine is currently not available for the prevention of the disease. So prevention by using vector control, insecticides, repellents, and protective clothing is a main strategy to control the disease. So these are the references which we have used in our presentation. Thank you so much for watching.